Alright guys, next traction splint up is the Sager. Biggest differences between the Sager and the Hare is instead of having two support beams that go all the way across, we just have the one. And this one doesn't necessarily go underneath the leg, this actually goes in between the legs. It's just a fair warning, can be very uncomfortable because of where this has to go, especially in our male population. So just be forewarned. It can be very uncomfortable, especially if it's performed right. So just like with the Hare, we're going to come up, we're going to assess our patient. If we feel like there's a need for C-spine precautions, we're going to have one partner hold manual C-spine. If the patient's unconscious, not breathing, and is pulseless, we'll start CPR. But for the purposes of this video, patient's alert, patient's talking, patient is upset because he's in a lot of pain. So again, just like the Hare, Sager is only for midline femur fractures. If there's an issue with the knee, lower leg, or if there's a pelvic issue, these are contraindicated. So we need to make sure that we're doing a thorough assessment to make sure that this is a true mid-shaft femur fracture. So when I come up to my patient, we are going to assess the injured leg. We're going to hold manual traction, which I'll have my partner now take over. At this point as well, we're going to check for CMS. We're going to check for pulses. If we have time, we will mark the pedal pulse site. So at this point, we're going to introduce the splint. And with the same precautions with the Hare, we do want to make sure that we are getting a good assessment, making sure that we're feeling the instability. The injured leg should be shorter than the uninjured leg. Notable swelling at the thigh, and definitely pain on palpation. So as we introduce the splint, it's going to sit high up, and we have our ischial strap. This needs to sit as high up as possible. Now we're also going to work on getting our ankle hitch set up. So unlike the Hare, the Sager has a weight-based component. So when we pull traction, we need to determine the patient's weight, and then approximately 10 to 15% of that is what we use to pull traction. If you are unsure of what the patient weighs, we can guesstimate. So we'll say that this patient weighs approximately 150 pounds. So down here, go ahead and let go of traction for right now just for the video. So down here we have a gauge. We're going to pull approximately 10 to 15 pounds worth of traction. You know, it's well noted on the side of the gauge. So you can do it in kilos, you can do it in pounds. Black is for pounds, so do about 15 pounds. So as we pull traction, just like the Sager, or just like the Hare, patient should be in decreased pain. The leg should be approximately the same length as the uninjured leg, and there should be some decreased muscle twitching. At this point, once we get adequate traction pulled, we usually like to secure the legs together. Also, before we do the securing, we need to make sure we are checking pedal pulses and sensory. Have the patient wiggle their toes. So, at this point, we're going to get our straps. We're going to secure the lower leg first. Again, below the knee. And above it. Once we're done securing, check your pulses again, check your CMS again, place the patient on the backboard, and initiate transport.